Hi, I'm Dr. Vonda Wright, and this is Hot for Your Health. Join us for conversations on the bleeding edge of science, health, and culture as we bring you tech innovators, thought leaders, and the movers and shakers who are transforming science fiction into your new health reality. Hi, everybody. I'm Dr. Vonda Wright, your orthopedic surgeon and longevity doc, and I'm thrilled again that you've joined me for another session of Hot for Your Health. Today, I have a kindred spirit. We've been talking behind the set, and I know that we would get along in the surgeon's lounge as we're waiting for our next cases. Dr. Jeremy London is a board-certified cardiovascular surgeon with more than 31 years of experience, not only educating the public, as you see him now on his wildly successful social channels, but 31 years at the bedside, preventing disease, curing disease, getting you through some of the most harrowing times in your life. Because, you know, Dr. London, my family dies of cardiovascular disease. So I have been there with my grandparents, and my parents are still living, thankfully. But you practice in Savannah, Georgia, and one of your training grounds is a hospital that's near and dear to me, which is, I call it Hospital of the Carolinas. I'm not sure that's its official name, but welcome to my little podcast, Hot for Your Health.
Well, thank you so much. I am honored to be a part. I really am.
You know, I've been, as we tend to do on social media, I've been watching what you're doing. I'm loving what you're producing and all the forms you're taking. But I wanted to step back because most of the general public doesn't know what an orthopedic surgeon, sports surgeon actually does. And I guarantee you, all they know about cardiothoracic surgery is you got to be really smart and you crack some chests. But that is not actually the nuance, the amazing part of what you do. Just tell people what it means to be a cardiovascular surgeon.
Sure. So the interesting thing is that has really evolved over the last probably 15 to 20 years. And so when you say cardiothoracic surgery or cardiovascular surgery, that all kind of gets lumped into the board certification for thoracic surgery, which years ago, that included both thoracic oncology as well as cardiovascular surgery that included the heart and all blood vessels, basically from the base of the skull, because everything above is the neurosurgeons or the brain doctors, really all the way down to the tip of the toes. And so the scope of the practice when I was in training included all of those things. And consequently, even once I got out in practice, that was still the case. I practiced all three things. I was a thoracic surgical oncologist and general vascular surgery, which I'm boarded in as well, and I have an interest there, as well as cardiac surgery specifically for the heart. And not to get too far in the weeds, but the long and short of it is each of those disciplines have gotten so big that really you cannot stay current and up to date and cutting edge and really good trying to do all of those things. So interestingly, even the training programs now require that you make a choice after your first year, that you're going to be a thoracic surgeon doing surgical oncology primarily, or you're going to be a cardiac surgeon. And I kind of went through that same evolution kind of on my own in practice after about 10 years, where I decided I can't be good at all of these things and be as good as I want to be at all of these things. So I chose cardiac surgery. I'm a much better cardiac surgeon than I am general thoracic surgery, because that was the nature of my training. And at the time, our technology wasn't as good for general thoracic surgery. So for lung cancer, for instance, for stage 1, small lesion disease, it was almost an exercise in futility to operate on these people, because we really weren't up to date with how to treat these folks with radiation that was really focused in chemotherapy and all these things. And I don't like an exercise in futility when I walk into the operating room, as I'm sure you don't either. We never want the risk benefits to be flat. We always want the benefits to be here and the risk to be lower. So it really became an easy decision for me to shift towards cardiac surgery, which basically involves diseases of the heart. And that comes in really kind of two basic buckets. One is blockages in the heart arteries that causes heart attacks and chest pain, things of that nature, as well as problems with the valves of the heart, both leaking valves as well as blocked valves. And that's, it's interesting because cardiac surgery really didn't see a lot of significant change for a long period of time, probably 50 to 60 years. I mean, how I was trained is very similar to the training from years ago. And I'm sure that you kind of had that same experience in orthopedics. And then suddenly there's some sort of breakthrough. And for the most part, that has involved much more minimally invasive approaches as it has in other specialties in kind of two forms. One is catheter-based therapy. In other words, going in through the blood vessels, typically in the groin, with very small devices, and we can replace and repair valves doing that, even with the patient awake, which is amazing. It really is. I mean, we talk to patients while we're replacing their aortic valve now. I mean, it's like, it's unreal. And they spend a night in the hospital. To what we call small access surgery. So the old, do you really want to be a member of the Zipper Club? The answer is not really, because it just takes a long time to get over this. As you well know, it's 3 months before you get full bony healing. And it hurts, you get micro movement of the sternum and all those kinds of things, and they have to baby their sternum, and you can't get them back up to full speed. Well, now we can do valve surgery through just a small incision on the front of the chest or the side, or most recently, we've even shifted to doing bypass surgery just through a small incision, either under the breast in women or the pec muscle in men. And that has really transformed, number one, the patients that we can operate on, these more infirm folks that we can really affect the quality of their life. But it's less traumatic to the patients as well. And so that's kind of a broad brushstroke of what I do and how it's evolved over the last 10 to 15 years.
Well, I'm really glad you shared that with us, because the feeding valves through a line or microsurgery, my father, who's 84, I told you offline that cardiovascular disease, like so many families, is what my family dies of, whether it's stroke or valves or heart disease. So my father had one of the first of those under pec procedures in the country. It was so long ago. I was still a resident. It was kind of experimental, but the story is remarkable because, of course, you're not breaking bones. So that's why I wanted you to explain to people what modern surgery is doing, because all we're left with is the ancient, we're going to wire your chest, which still has to happen occasionally. But you guys have advanced so much that there's so many better options for people. But go ahead.
What comes to mind right away when you say that? My general surgery program director used to say that surgery is an excuse for what we don't truly understand in medicine.
Oh,
which I thought was amazing, coming from the chairman of a big surgery program, right? Right. I know, you're like, wait a minute, this is what I love to do, but it's an interesting perspective. Look at peptic ulcer disease. Mm-hmm. For instance, when I was in training, we used to do all these crazy operations where we remove part of the stomach and cut the nerves to the stomach. Yeah, cut the nerves to the stomach to decrease acid production. And now we know that it's related to H. pylori, a bacterial infection. So there's a lot of these kinds of things out there. And I'm not suggesting that we're doing something now that's wrong, but that these are, it's an evolutionary experience. And all you can do is take the data that we have at a given time and apply that in the best way that we can. And so it is moving in a forward direction. Hopefully in my lifetime, I won't see cardiac surgery go away entirely, but I think it's unlikely.
Well, I think what you point out in the evolution of our practices, and that certainly has been for me. When I started, we were just transitioning to arthroscopy, and now I don't even make incisions. I use needles to remove knee problems. Isn't that amazing? And people walk the next day. So, but what that says is that doctors and surgeons need to continually be curious and not be too proud to say, I did it that way, but say, how could I do it better? I'm taking care of human beings, right? Mm-hmm. So that's one of the joys of being, still practicing. I mean, I could legitimately hang up my scalpel, but that's a hard decision for me. So because it's the curiosity, I want to keep learning all the time. But I want to tap into your brain because you've been generous to give us an hour of your time. And a lot of people don't know what they want. They know they want to be healthy. There's a lot of information out there. So I thought the way I would have you just clarify for us is let's do it by decade, right? Let's start at, and you know what? Let's start at 30, 35. When I don't know what you call it, but I call 35 to 45 the critical decade. Young people better get it together because things are changing soon. And while you're still got the vigor of youth and your hormones, let's get it together. So what do you say from a cardiovascular standpoint we should be doing between those age ranges, 30 to 30, 30 to 40, 35-ish?
Well, I think your moniker of you better get it together
yes.
is absolutely directly applicable to where they need to be when they're thinking about health span and lifespan. Mm-hmm. For most people, unless they're heavy smokers, diabetics, have a family history, obviously those put you in a different risk factor category as far as how much you're going to be able to mitigate at that point, depending on kind of what got you there. But typically you still have a wonderful opportunity to move the needle in a really meaningful way when we talk specifically about cardiovascular health. And I know these are things that you are very familiar with and near and dear to your heart. I really think it comes in a bifurcated way. First is that we are only as good and only as healthy as the food that we put in our mouths and the environments that we expose ourselves to. Our bodies are such wonderful organisms all the way down to the cellular level. Every cell is striving to be in balance, that idea of homeostasis. And so that then is all translated through the body. And so you want to help your body maintain that balance. And I think what's happened in this country, primarily with food, because if you think about it, we internalize 70, 80% of the outside world through our mouths. I mean, obviously we're breathing air. Our skin is a viable organ, and we certainly do bring in, we create vitamin D, and we also have toxins that we absorb through the skin, but it's mainly what we put in our mouths. And so I think that creating a thoughtful nutrition program that works for you is such an important place to start. Now, that being said, we all have our own instruction manuals, right? And that's okay. There's a lot of information out there about nutrition and a lot of opinion about nutrition, some pretty good, some not so good. But I think in general, you have to figure out what works for you. And there's a lot of different ways to do that. So I think that nutrition and your dietary choices are foundational, particularly when we look at our society. I had an interventional cardiologist years ago say to me, if a farmer looks at their crops and they're all sick, where's the first place they look? It's in the soil. Mm-hmm. And I mean, sit in an airport and watch the world go by and think, my gosh, increasing heart disease, diabetes, cancer, all these things. This is our soil. So I would start there.
Okay.
And then I think the second piece, particularly in your 35 to, early 40-year-old individuals, is a solid, sustainable, durable fitness program. You got to move. I think that I have had an evolution personally over the last probably 35 years,
Yeah.
where my balance of that fitness program has certainly changed. I am a firm believer that I spent way too much time doing heavy endurance sports.
Yes.
If I had spent more time doing resistance and strength training, I'd probably be in a different place now. But I think that if you really want to get, kind of down the Jimmy Neutron pathway here, obviously you want a solid mixture that works for you, that you're going to get up every morning and you're going to be consistent. And more importantly, you're going to miss it if you don't do it. And so you want that mixture of strength and resistance training that's going to increase your muscle mass, because I really think that, as many say on social platforms these days, including my lovely host, muscle is such a key component to longevity. And I truly believe that. I believe that for myself. There's also good evidence that VO2 max, or our body's ability to extract oxygen, is a very strong predictor of how long we live. So you absolutely have to balance those things. And again, just like the nutritional piece, it's all personal. But you just want to make sure that you are getting those components. So I think in that age group, and really this kind of applies all the way through, because I don't want to imply that, like, if you're 45 now it's too late to do these things, because you and I both know that's just not true. The impact that you can have is dramatic at each of these stages. And I think particularly from a cardiovascular risk standpoint, you have to remember that in general, cardiac disease, particularly blockages in the heart arteries, is a symptomatic disease process, typically speaking, unless you have diabetes and your nerves aren't working properly or something of that nature. Typically, it's a symptomatic process that you exert yourself and you experience shortness of breath, easy fatigability, or formal chest pain, and then you rest and that pain then goes away. So if you can do those things that we just talked about, really, a vigorous aerobic training several times a week, and you can do some sort of resistance training without feeling like you have to scale those things because you physically can't do them, the likelihood of you having significant cardiovascular disease is pretty small, really under the age of 40.
Gotcha.
Now, yeah.
So then I have several sons who are tipping the scales towards 40. What should I tell them to do? I call 40 true adulting. You need some life insurance at that point,
Yeah.
What do we do from 40 to 50? That's if we've gotten our baseline, and if we haven't, can you please do what Doc just said? But what do we add during the next decade?
Sure. So I think that there are certainly markers, if you will, that are worthwhile following, particularly once you reach that age, and particularly if, like yourself, if you have a strong family history of cardiovascular disease. The earlier you identify these types of things, then of course the more opportunity you have to affect change, starting with lifestyle alterations, and hopefully being able to avoid me later in life, or even potentially having to take medications. And so I think that they're fairly simple markers that I think need.
Tell us what to have order.
Yeah. So, I think starting with a standard lipid panel, which includes HDL, LDL, and triglycerides, the triglycerides in particular as a marker of overall health. Mm-hmm. I think fasting glucose state is really important because I think that there is good data that stable glucose levels and preventing big insulin spikes and consequently potentially what we refer to as insulin resistance. Obviously, the way that happens is you get too much sugar and the cells just can't manage it. Then you've got all this extra glucose floating around your body, and that really affects the inflammatory process. So as simple as it sounds to check your blood sugars, it's really important. And the cool thing is you can really make a meaningful change with some simple alterations in your day-to-day with diet, movement, etc. And so those are, those are really important. And obviously, some basic kind of baseline labs looking at your hemoglobin level, which is the cells that carry oxygen, as well as looking at your overall electrolyte panels that would include potassium and sodium, calcium, phosphorus, magnesium, all these baseline things, and your kidney function, which I think is also important to have a baseline. Are you going to pick up a lot of abnormalities? Not necessarily, but if you do, then it's important to know early on. Then we kind of get off into some of the more non-invasive testing, that is out there. You read about the calcium scoring tests, which, I think a lot of folks know it's out there, and you don't need a prescription or a referral from a physician to get this. They're about $100, and you can really go to one of the freestanding radiology facilities and get one. But what does that tell you? Well, basically, it's a regular CT scan, which is an X-ray that looks at the body in slices. And what it can do is it can quantify on a given scale the amount of calcium buildup that you have in the heart arteries. Now, remember, this is a screening test. Just because that number is high, remember, I started this conversation saying that it's typically a symptomatic problem. There's many people that have high calcium scores that have no symptoms. They still need further evaluation, but it's not a death sentence. And I get those phone calls all the time from friends in particular. So it's for the scales vary, but there's typically somewhere between 0 and 1,000. And they're really helpful if it's 0 or if it's 1,000, right? If it's totally normal or really abnormal, then you kind of know what needs to happen. Either nothing, and you don't have any calcium buildup, or you need to be evaluated by a cardiologist, at which point that kind of takes you down another road. It's that middle ground that it can kind of get confusing for people. Most of the time, if that happens, you are evaluated by a cardiologist and typically have a stress test. Again, another non-invasive type of testing. And what that involves is being placed on a treadmill, and you have EKG pads placed on, and they then exercise you at different elevations and different speeds, asking you if you're having any symptoms first and foremost, and then watching your EKG up to a maximum amount of effort. Again, trying to tease out, is this significant or is it not significant? If it does show something, then that takes you to the gold standard, which is cardiac catheterization. And that involves a small catheter that either goes through the artery in the groin or now in the wrist, which is great because we don't have to have patients laying flat afterwards. And then dye is placed in the heart arteries, and it gives you a roadmap. And the question is, are the roads open all the way down, or are there blockages in those roads? Many times, even with that invasive procedure, it's normal, particularly in patients that aren't symptomatic, but you almost are forced to go down that road if the stress test is abnormal. And the last is an echocardiogram, which is something that, I think that it's not a standard screening test, for the general public, if you will, but let me tell you kind of the information that it offers. First and foremost, it is the best way to look at the valve function in the heart, because just like an ultrasound during pregnancy, the resolution is really good. You can see fingers and toes and the face on those wonderful ultrasounds. Same thing when you look at the heart, and you can actually see that the valves are moving properly and that they are competent or not leaking or potentially blocked. So it does a great job of looking at valves. I think as important, if not more important, it looks at heart function. And heart function is a critical indicator of longevity, as well as risk for early mortality, as well as risk should you need to undergo a cardiac procedure. And that's based on a fairly simple calculation. So every time the heart squeezes, it measures the amount of blood that is ejected out of the main chamber. It's called ejection fraction. Now, interestingly, a normal ejection fraction is around 65%, because every time the heart beats, not every drop of blood comes out. A certain amount stays in. So a normal ejection fraction is around 65 to 70%. So that's kind of the non-invasive to potentially invasive track that people would take. Does that give you kind of a little bit of a contour?
I think it's a nice roadmap because, the heart is scary to people. Mm-hmm. You only get one of them. There's not a dual, it's not a paired system, right? It's a paired within the heart, in and out, but you get one heart. So it's a really scary thing, especially if we don't know what's going on. So that was a wonderful way to walk through for people. At what point, and I think I've seen you discuss that, do we get things like the lipo, advanced labs? When does that fit into our lives?
So that's now. And I intentionally didn't lay that out as far as the initial discussion, because I think it's important that you kind of have the groundwork. Now, that's the next drill down. So why are we hearing about all these things? Well, because we're learning more that it's not really, you hear LDL is bad cholesterol. That is true, but not all LDL is bad. And just because your LDL is elevated doesn't mean that you're necessarily at a significant increased risk. So let's break it down a little bit further. When we're looking at LDL, and I will say I am not a cardiologist, I am a cardiac surgeon. So this is a little out of my wheelhouse, with the exception of the fact it's something that I'm interested in.
Yeah.
So LDL comes in different particle sizes. And so getting your LDL particle size checked is very worthwhile. So it's that ratio of little particles to big particles. Why is that important? Well, the big particles bounce off the vessel walls. They don't penetrate the vessel walls. The small particles can penetrate the vessel walls, which causes a break in the integrity of the vessel wall, which then sets up this cascade of the body saying, there's something wrong. Now we've got to go fix it. And the first thing that happens is other small particles get in right behind it. So you get this cholesterol buildup, LDL buildup in that location. Okay. Yeah. So that's one that's really helpful. And there are ways, just with simple lifestyle changes, again, with things that we've discussed with nutrition and with exercise, that you can alter that ratio.
And I've done that. I mean, when I we're not going to talk about my menopause, but we could, but at the time, like so many women, and we have a little bit of congenital high cholesterol in our families, but it was off the roof. So in addition to making hormone decisions for myself, I changed the way I worked out, because I too was a long distance marathon training. If I wasn't running and dying, I wasn't working out. And I totally changed, and I focused more on building muscle, and my lipids corrected. And so it is possible.
Amazing.
At every age. But that was something that we did. We saw high LDL. We measured my particle size to see if this ominous number was really ominous. So what do we do in addition to the things we've already talked about once we hit 50 and the Hallmark Rest in Peace cards are coming? And, we're most people, not me, I don't even know if I'll ever retire, but most people are within a decade or so. What do we do once we've gotten the Rest in Peace card from Hallmark, or the worst AARP card showed up?
I was just about to say it. Yes, I was just about to say that. That and the emails from AARP that I immediately delete because it couldn't possibly be for me. Yes, there's no way. So obviously things change, and our risk factors change. And again, there are several buckets where we have to risk stratify individuals as far as what we should do. And interestingly, I'm sure you have been hearing the buzz of the change in the risk factor calculator recently, as far as where people are. And as a result of that, there's been all of this kind of secondary discussion of, okay, now 40% of patients are not going to need to be on statins because they're not in that medium to high risk category. Well, I agree with that, but let me back up and say that statins have saved a lot of lives and statins work. So I don't want to vilify statins, but I do think that this goes back to what you were saying about being curious and being willing to re-examine situations. So I do think we're going to have a shift, and it's not something necessarily to become emotional about. It's something to say, well, okay, we actually have a better risk calculator. So now we're going to be able to shift where these people actually fall just based on age, what have you. There's a lot of different components to go into it. Have they been a smoker? Are they a current smoker? Family history like yourself, or what are their lipid profiles? What are their other risk factors? Diabetes, prior strokes, anything of that nature. So let's just take the healthy, otherwise, minimal risk factor 55-year-old, let's say. Okay. Let's move them into the middle 50s. Like, what do they need to do? Well, I think that obviously, regular examination and evaluation by either your family physician or a cardiologist is always appropriate, because this is a progressive disease process. Like when we do an angiogram, a cardiologist does an angiogram, a catheterization, and we see all of these blockages, they didn't happen overnight. And so you want to be as proactive as you can in these situations. And so regular evaluation may pick those things up at an earlier time before you present with a heart attack or a stroke or things of that nature. So I think good, close, yearly follow-up makes good sense. But again, I think that now is when it's even more important that nutrition is maintained, that your protein levels are actually increased, so that when you do your resistance training, you actually get the real benefit from that. That's, where the advantages of balance and functionality and getting down on the floor and getting off the floor as you continue to age, and, being able to maintain a level of resiliency should you end up breaking a hip or have orthopedic injuries that are more likely as we age. I think it's kind of that whole body type of advantage. But from a cardiovascular standpoint in particular, maintaining a good common sense whole foods diet, whatever that looks like for you, and a fitness program that you can continue to maintain is what is going to help you mitigate this risk as we continue through these years.
Let me ask you this question. It's a different approach to, you're right. I advocate protein intake because I know that skeletal muscle synthesis is directly related to how much we feed that. It's skeletal muscle. I do not know the cardiac literature. Is there evidence that adequate protein maintains the cardiac muscle? Because people out there, we have 3 types of muscle. Skeletal, which is primarily what I deal with, cardiac, which is what Dr. London deals with, and then the smooth muscle that happens to be in our guts. So does taking enough protein help maintain the muscle of the ventricle itself, or the heart is so robust it doesn't really affect it like it would a skeletal muscle? Do we know that?
That's what I was going to say. I'll have to be very honest with you. I don't know where the basic science research lands with this, but it's a very interesting question. I can tell you what my sense would be is, first of all muscle requires protein to be maintained there. I think that's a given that we can probably assume. The other thing is, like the brain, cardiac tissue is the most preserved in starvation type states. And so, and again, I don't know where the research would come out with all of this, but my sense would be, when the heart can actually use lactate as an energy source in times of true fight or flight, I think it would be the last place that the body would go to draw proteins for additional. Yes.
Yeah, thank goodness. We can't be taking from the ventricle, for God's sake.
Right. But I don't know the answer is really what I would say.
Because I don't know either. The other question I don't have an answer to, we're going to move to how men and women present in a minute. The other question I don't know the answer to, I'm going to look it up if there is any data, is there is a thought. Originally, there was a thought within my world that muscle was in its house, bone was in its house, and they weren't even neighbors. But now we know that osteoporosis and sarcopenia are part of the same ecosystem. And because muscle and bone are master communicators, sending out their various kinds to communicate. I want to know if skeletal muscle is talking to its cousin cardiac muscle. Like, do we send signals to the heart that aren't related to how much energy it needs to? I don't know that answer. That would be so cool to find out.
Absolutely. And my blink response to that is that none of these things happen in a vacuum.
Right.
And the human body is both complicated and complex all at the same time, right? Like, complicated is, the escape velocity to put a man on the moon, and we know what it takes for a woman on the moon to send the rocket there. Complex is like an ecosystem, and there's a lot of moving parts, and the human body is both of those things. And so, I think you and I as surgeons kind of focus many times on the complicated. Like, we see the problem. We understand for both of us, there's a structural problem. We can fix that structural problem. We know that that's going to impact the natural history of this disease process, and you're going to feel better, enjoy activities of daily living for longer, and all of those things. But we're also operating on a very complicated, complex system, people operating on people. And so none of these things happen in silos. And so I think that the answer would be it has to. Now, do we truly understand how that works right now? I don't know the answer, but I too will look that up because that's really interesting.
Yeah, really fascinating. Well, you and I were talking earlier, and the young people in our audience, Max, your son will not know this. I'd ask my daughter. She's like, what? There was a movie long time ago called Yentl, where a young woman wanted to have access to the Torah, the Jewish religious book. But the only way she could get access was to pose as a man. That is not unusual when it comes to health, or specifically cardiovascular health, because most of the studies, just because studies are very expensive, were done in men. So we assumed the way the man gripped his chest and fell down with a heart attack was the same way women presented. But educate our public so we don't fall down in the airport with a heart attack and not know it. How do men and women present with their cardiovascular disease differently?
Yeah, I think this is a really important topic, and it's something that I get questioned about all the time in my office, but particularly now as this information is getting out on the social platforms. And I agree with you. For years, medicine has been a male-dominated profession. And I mean that like in a more generic sense than I do pejorative. But yeah, it's got a lot of negative connotation too. It's men creating, diagnoses and therapies for men primarily. And so what's happened in the cardiovascular realm, and it's exactly as you point out, I call it the TV heart attack. Like, that's what the Fred Sanford TV heart attack, right? Where, I'm coming to see Louise, and I'm having crushing, the typical, the symptoms. There's an elephant sitting on my chest.
Yeah.
And there's pain going down my arm, and it's going to my jaw. We know what's happening. That patient comes into the ER, and they are rushed.
Yes, to the cath lab. They're up there.
And at least they're evaluated immediately. So then and granted, there's a spectrum for men too. Let's not get too polarized in the conversation. There are many times are warning signs and what have you, but for the sake of simplicity, let's call that the male heart attack. So
sure.
What's different for women? Well, women too can present with crushing chest pain and in that similar way, but more commonly, the chest pain is different in nature. It tends to be sharp It may not be as localized. It may be burning pain. And that kind of leads into the next part of this of what I call soft symptoms. And those are the things that people don't typically associate with the heart. Well, what are those? Nausea and vomiting, lightheadedness, easy fatigability, things that are kind of non-specific, if you will, that many times, and I mean this in the best possible way, that we're like, oh, well, she's just having an anxiety attack, or this is just the stress of an emotional situation which may in fact be true. But what happens is, and it happens on the patient side too, because these aren't obvious symptoms, patients say, well, what's wrong with me? Like, I don't really know what's going on. So they delay going to the hospital. So there's the first big delay. Then the evaluation process, they show up, and I hate to be overly critical, but they're not taken seriously with the symptoms because there's not, the antenna frequency is not set properly to evaluate women in this situation. So there's delay number two for these. And so what happens is they go through this whole cadre of, is it your gallbladder? Is it some sort of emotional crisis that you're going through with these? And then all those things are negative. And then what's left is, we better check what we call a troponin or an enzyme.
Right.
Yeah. That actually could delineate as this a heart problem. And I think that's one of the reasons that you read these articles about outcomes from heart attacks being worse in women than men. And I think that it starts, and there's other reasons too, but I think it starts with this delay. And why would that be? Well, if you think about it, a heart attack or even just angina is where a portion of the heart muscle is blood starved. So you have a blockage upstream that's not able to give nutrients and oxygen to a portion of the muscle. Well, what fixes that? It's getting blood flow there. Well, time equals heart muscle saved. And as we alluded to in the beginning of this talk, when we were talking about the echo and heart function, that's what determines long-term survival. If you get there soon enough, the heart muscle is hibernating and it comes back. Mm-hmm. If it's too late, that portion of the heart turns to scar. Mm-hmm. And so when you have this upfront delay, that risk goes up significantly. There is a national standard of a patient showing up in the ER with a heart attack of 90 minutes from when they hit the door to when blood flow is restored to the heart. And so because that seems to be the sweet spot, if you will, to put most people in that high survivability category. So that's why that has been kind of the national, American College of Cardiology standard that this is what needs to happen. Now, there are other reasons why we think, and again, this is getting outside of my bandwidth a little bit, of why. So the question is, well, then why do women present differently than men? If it's blocked arteries, I mean, it's blocked arteries. Our hearts work the same, right? Well, women tend to have the smaller arteries of the heart affected more than the larger feeding arteries and what we call microvascular diseases. And so the way that you present with that, when you don't have these large territories of muscle being blood starved and suddenly all the heart muscle cells start dying, which is what causes the pain, it's a much more subtle process, In addition, and I'd be interested to know your opinion on this, particularly in women that are postmenopausal and they don't have the estrogen as an anti-inflammatory and what have you, it changes the pain response in the body, particularly with the way that the pain is interpreted and the symptoms are interpreted, because it's so similar to a lot of the other symptoms with menopause that it's hard to delineate. And so I think and that's one thing that I've read about recently when I've been diving deeper into this, estrogen cardiovascular disease connection, and that keeps coming up over and over again. And so I think that there's good evidence that, I don't know if it's proven, but it's certainly worth, continuing to explore.
Well, something that women in perimenopause, and I had this actually, experience a lot is heart palpitations. I had really sharp chest pain on my PMI. I'm like, what is that? And I'm holding it like that, panicking because I know my history. And at that time, I didn't know. I mean, I consider myself a menopause, very educated, authoritative person now, but at the time I wasn't. So, I called up my cardiologist. I'm like, Ricky, you got to do a stress test on me. I think I'm dying. And thank God my heart was fine. But women don't know.
Yeah.
Women stay curious and seek out the questions instead of what lots of people do. Lots of people say to me, men and women, doc, I've got a really high pain tolerance. I just thought it would pass. So, as we all remain curious, we're learning more and more. So I don't have the end answer to everything estrogen and heart, but I do know, to your point, a lot of midlife women have an increase in what they think is their heart. But it bears checking out. It does not bear sitting at home and then having a real heart attack, because that's simply devastating. So, well, I've loved this. Look at all my notes, Doc. I learn all the time. I never stop learning so thank you for your time. So, go ahead.
I was going to say, it's been a pleasure.
Oh,
I've really enjoyed it. It's been a wonderful back and forth, and I've really been looking forward to it. And this has exceeded my expectations exponentially.
Well, in the future, we'll have you back as I voyeur you more on Instagram. Everybody,
it's mutual. It's mutual.
And you're also on TikTok. I'm not much there, but I'm going to have to go check out what you guys are doing. Anywhere else people should look for you? Besides Atlanta, Georgia, if you need great.
We have gained a fair amount of traction on YouTube, and we are starting in the long format, because what we've discovered is, in 90 seconds, you give folks just enough.
Yeah.
But to talk about the difference between a panic attack and a heart attack, it's hard for me to do that. So we had this really engaged audience that has really kind of flocked to wanting these longer, either 15 to kind of 40-minute discussions on what we seem to think are the most popular topics. In addition, we have a free newsletter that goes out once a week that we cover the health, lifestyle, as well as cardiovascular topics. And we have a members community that allows individuals to have direct access to me and to other kind of like-minded folks that they kind of go back and forth in the community. It's really been kind of fun to watch. And then I do live Q&As with the community at least once a month, sometimes more often. And so those are kind of our basic platforms, and I've really enjoyed it.
Oh, I think it's just great. So, ladies and gentlemen, Dr. Jeremy London, thank you so much for being with me today.
Thank you so much.
I'm Dr. Vonda Wright. See you next week.